Hi, my name is Anne Benner, and I started doing research under med school with Henrik Christensen, where I did a study on idiopathic ketotic hypoglycemia. We have made an article about it, and it's under peer review. So, what is idiopathic ketotic hypoglycemia? It's a diagnosis of exclusions when other known causes to hypoglycemia are excluded. This means that we have to exclude hormonal and metabolic causes to ketotic hypoglycemia, including growth hormone deficiency, adrenal insufficiency, some types of glycogen storage diseases, and other causes. In our study, we specifically identified patients with an IKH diagnosis, but who actually showed up to have a glycogen storage disease 9A. So we have illustrated here that there is an overlap between the IKH and the GSD IXa diagnosis, which means that some of the IKH children should actually be reclassified to have a GSD IXa or maybe other GSDs. What are glycogen storage disease 9A? It's caused by a PHKA2 DNA variant, and it causes the inability to break down glycogen to provide the body with glucose after prolonged fasting, illness, or recurrent after an overnight fast. So GSD IXa is the only GSD subtype where the mutation in the gene is located on the X chromosome. And this is important to know when looking at the family history. So it means that the mutation in boys can only be inherited from their mothers. Just to point out, to establish the diagnosis of IKH, GSD is usually excluded by normal liver parameters and absent of hepatomegaly. A normal IM glycagon test further argues against some of the GSDs. Where did our study begin? It started with one family with a 6-year-old Caucasian boy with idiopathic ketotic hypoglycemia at onset of 8 months. He had symptoms with repeatedly morning fasting hypoglycemia with fatigue, vomiting and shivering. His lowest blood glucose were measured to 1.7 millimole per liter or 32 milligram per deciliter, and his highest ketones were 1.8 millimole per liter or 32.5 milligram per deciliter. He had a lot of normal investigations, including normal hepatic ultrasound and liver parameters. He had a normal synactin test and IM glycagon test. He has a normal urine metabolic screen and carnitine profile, and his plasma insulin suppressed during hypoglycemia. And he has no dysmorphic features. The only abnormal finding was a subnormal peak growth hormone at stimulation test, and growth hormone treatment at the age of 2.5 to 3 years old didn't prevent hypoglycemia, and he was normal at height. How did he get from the IKH to the GSD IXa diagnosis? He didn't have any liver manifestations and was not suspected for GSD, but family history prompted re-evaluation of the IKH diagnosis on suspicion on an X-linked hypoglycemia. The pedigree here shows the family, and the arrow points at the proband. The gray are hypoglycemia symptoms in childhood to present age, and the hatch are hypoglycemia symptoms in childhood. So as you can see, there's an accumulated incidence of hypoglycemia in this family in an X-linked pattern. We made some genetic investigations, and a GSD panel was made, and it found a novel missense mutation in the PHKA2 gene. We did some interpretation by the MCMG guidelines, and it found the mutation to be pathogenic. 3 children from 2 other families experienced the same symptoms and had the same variant. So we expanded the study to include 8 families, 5 from Denmark, 2 from Canada, and 1 from the US. In these 8 families, 12 children were suspected or diagnosed with IKH. Whole exome sequencing and next generation sequencing panels were made, and it found 2 known pathogenic, 3 novel likely pathogenic variants, and this led to a new diagnosis of GSD IXa in 11 of the patients. So we can call the children with the GSD IXa, but without the liver manifestations, for the ketotic hypoglycemia only GSD IXa. In the 8 families, we did some genetic interpretations using in silico analysis and interpretation by the MCMG guidelines, where the 2 known pathogenic variants were found in 4 families. There were 3 families with novel likely pathogenic variants, and 1 family had a variance of uncertain significance. The severity of the KH in the children varied from occasionally after prolonged fasting or illness to more frequent and recurrent after an overnight fast. So the lowest blood glucose in the children were measured to 1.1 millimole per liter or 20 milligram per deciliter, and the highest ketones were measured to 5.1 millimole per liter or 93 milligram per deciliter in the children. The liver counts and the ultrasound of the liver were normal in the children, but there were some exceptions. At follow-up, an 18-year-old boy had normal-sized liver on ultrasound, but it showed hypoechogenicity of the liver. A liver biopsy showed discrete fibrosis, but without steatosis, and he had a slightly increased CAP value. But the liver stiffness was normal, and at this point, he has been asymptomatic for 6 years. Another boy had occasionally mildly elevated SAT levels, and a third boy's ultrasound showed hypoechogenicity of the liver at the age of 3.5 years, but at repeat ultrasound at 5 years of age, it was normalized. We also did family investigations, and we identified family members with a PHKA2 variant, but without an history of ketotic hypoglycemia and without KH on formal testing. So this means that the same variant can be seemingly asymptomatic in some, but cause KH in others within the same family. So this study expands the phenotype of GSD IXa to a continuum from a seemingly asymptomatic state to the ketotic hypoglycemia only GSD IXa to the more classical GSD IXa with hepatomegaly of varying degrees and growth delay. We concluded that the GSD IXa patients with a milder phenotype with the KH only are most likely misclassified as having IKH unless genetics are performed. It is beneficial to figure out the right diagnosis and reclassify the IKH to the KH only GSD IXa because family investigations can identify affected siblings and parents and other family members with the KH. Furthermore, KH children with a diagnosis of GSD IXa have a documented disease, and it's more than just a normal variation, and they should be monitored for the KH, treated, and have a longer follow-up than just to the age of school start. But the good news is that GSD IXa is usually self-limiting, and most of the patients become asymptomatic in adulthood. But attacks of KH may still occur in adults, as we have shown. Finally, I would like to thank the families with the KH-only GSD IXa who have participated in this study. And if there is any questions, Henrik and I are ready in the Q&A. So thank you.